So please feel free to ask questions, even in French. Doesn't matter. We'll do the translation. And I will start with one question. You are all working in different countries. Maybe both of you are in the same Netherlands. But I wanted, it's a discussion we had just previously during the coffee break. What could be the place of psychologists in healthcare setting to improve all behavior around patient safety and quality of care? What's the place in your country of psychology? Do you have them in your walls? Is it expected? Is it needed? What's your feeling about that?
Perhaps I start. In Finland, we don't have a psychologist, but we have in nursing this kind of holistic approach. And for myself, I have reviewed quite a social construction models, and I have published one possible model to search, because no model so far explains the adherence of or former compliance of the personnel. It is a very complicated issue, but absolutely there is room for psychologists in this team, in education and in modeling and researching the reasons.
I can say for Black Box that the debriefing is being led by psychiatrists in order to make sure that everyone has the same input.
No, we don't, and this is a key question actually, because I think we know lots of things that need to be done and they're not, and we keep on guessing on why they're not there. I think we need other focus, other way of looking at things in order to understand better the process. So I think psychologists, anthropologists, and social sciences in general are lacking in order to understand better what's going on. Thank you.
Rosemary, what's your feeling with UK?
I was just thinking while people were talking about our experience, which tends to very much talk about what the infection control team does. And for me, it's about how we work with other teams with other expertise to support our work. My personal thinking is moving very much towards how we use the skill of psychiatrists or others and quality improvement teams to actually help us achieve things that we know is an issue. So we're not there yet, but I think the thinking is moving in that direction. Yeah.
And do you get these skills in your healthcare settings or hospitals in UK?
Do we get
these skills, all these specialists, psychologists in hospitals? Yeah.
No, some university hospitals have access to specialist expertise, usually big university hospitals, not general hospitals. But what is emerging is that some hospitals are thinking very differently about the membership of their infection control team and are employing nurses working or having come from other areas such as renal or midwives. We have infection control midwives now. We have renal nurses that lead infection control programs, for example, on improvements in vascular line care. So they're not from traditional backgrounds. So many do not even have training in infection control, but they're able to bring the skills from other sectors and apply them to infection control. But what's really interesting is sometimes how they are received by their infection control colleagues or not. Another story.
So all this about collaboration. Yeah. Pierre.
I have a question to Fernando. He knows that I'm very impressed by his mandatory course in infection control for medical ward chiefs in Chile. 80 hours course for a medical chief is nearly a specialist course for us. And even in a wildest dream, making them follow a 20 hours course on standard precaution, it's something that we don't dream about. So can you tell us a little bit more about how you achieve that and What are your results at the moment with all these medical doctors in chief in charge of the ward?
Okay, thank you. First of all, I have to say that it's not the 80 hours, it's 80 hours plus 20 hours of standard precautions. That's a prerequisite. Having said that, it hasn't been easy. The first thing you have to know is that we have had resistance and that they even took us to court, saying that how can we make it mandatory? And the court said, it's free, it's for the good of patients, it's done in service, it is mandatory, period. So that's the end of the story there. Now to have people do it is a different issue. So we started with a management goal that the manager of the hospital has to comply with a 20%, then 40%, 60, and next year has to have 80% of compliance. This CEO has a medical director, and we already have 87% of them with the course in, and the medical chief of services, we have reached a 57%, which is a bit lower than our goal for the year. But what's so important is that it has turned into a hospital goal. This is not a matter that they choose by themselves. This is a hospital goal, and they have to understand they're working in an organization now. If they were in the private sector, nobody would say a thing. It's in the public sector, they would have to do it. Second thing is we understand why is the resistance, and we try to explore a little bit, and I think that the resistance is the embarrassment in case this is an evaluated course. They are embarrassed that they perform wrong, badly. They don't get a good mark. So you just get a pass or no pass at the end of the course. And the third thing is that when everybody does it, you follow the herd and do it. So I think that that's what's happening now, and from the 20% to the 60% almost we're reaching this year, I think we're not doing too bad. But there has been resistance at the level I told you. And then the course is tailored in the language of the doctors. It's got a lot of evidence on why you do it. So after you read the evidence, very succinct. It's very brief, a line or two, lots of references. They love it. And then the question is straight to the point, nothing too complicated. I think it's catching up. And we want to change culture. We have to change this intermediate management level that is really key for changing practice, particularly medical practice, which is our goal now.
Very interesting. Any questions from the audience? No, you're going to make us do our job, aren't you? Thinking of questions here. So, okay. So I have a question for the audience. It's very simple. You just have to raise your hands. We have our four presenters here today who have talked about different elements of work to improve infection prevention and control, all of which involve people and changing practice. So we have Fernando's work, number one, around surveillance and using surveillance to improve practice with infection control programs. We have our black box, use of the black box in surgery to debrief teams to help them learn from mistakes. And we have Taya's work on aseptic practice in operating theatres and how to work with nursing teams to understand the barriers and the stresses relating to that. And Frédéric's work on using lean technology to problem solve a complex but multidisciplinary issue. So number 1, 2, 3, and 4. So can I take a quick vote from the audience if you think you would find it easy or doable, not necessarily easy, but perhaps doable is the right word, to implement number 1 around surveillance programs and infection control programs? Not so many. Number 2 around black box. Put your hands up so I can see them if you're interested. Oh, okay. So number 1, hands up. Oh, very good. There's no competition here.
No.
No. Number 2, black box technology. Hands up. A few. A few. Number 3. Hands up. Listen. Number 3, aseptic practice recommendations. Okay. And number 4.
There is a translation, there is a gap.
I can't hear the translation. Number 3. And number 4. Nah, I thought, okay. So that's interesting. That's interesting. Okay. So, a question here?
Je peux la poser en français, vous traduisez, s'il vous plaît. Bonjour, Mathieu Lorenz de Metz. La question qu'on peut se poser pour entraîner nos collègues dans ces démarches-là, c'est d'avoir des données sur les outcomes, la iatrogénie. Est-ce qu'on a des données, alors sur les programmes de l'OMS, a priori oui, hein, mais sur le fait d'améliorer les comportements en salle, de limiter l'ouverture des portes, est-ce qu'on a des données qui peuvent prouver qu'on améliore les taux d'infection ou les iatrogénies au sens large? Données chiffrées, évidemment. Merci.
Do we have results of all the improvement we can have around behavior in the operating rooms in terms of outcomes, SSI, all adverse events? So it means that are we getting results from what we are doing in the operating room? When you are talking about traffic flow, do we know if there is an impact on SSI? Do we know if there is an impact on all outcomes?
Can I respond in English? Hopefully.
Yeah, of course.
Well, they looked at the data, if it has an impact on the SSIs, but the data set wasn't clear enough to make the link. So they tried, but we didn't have the results at the time.
Oh, may I say something? Yeah. Well, this is a problem we're going to have in every hospital for 2 reasons. One of them because hospitals don't perform too many procedures as to have enough power, and then because infections are already quite low. So I think that this is a call for multicentric studies and because if there is good science there, then we have to use it, and we can't afford losing it just because we have small samples.
I think it's really important to take all levels of evidence and look at it pragmatically in terms of, is it the right thing to do, even if we don't have really, really strong data with, the best level of evidence that we can find. Taya?
It occurred to me that when I have tried to get evidence for the necessity of the aseptic practices, it's related to your question. Opening doors was one of those statements in my service also, that we should not try to explain it by the big outcome, the surgical site infection, but start, for example, the contamination. Like there are studies from 1927 are the first studies related to what kind of gown you have, cotton or disposable or what. So we have to eat the elephant in pieces. So, but it is important to cut the costs by take off unnecessary. Some call them rituals, but I won't like this word at all, because we try to do the best for the patient, but we have to respect also the taxpayers' money. So we have to have a reason why we are using this intervention, whether this is necessary or not. And we have managed to take off already some, but these new ones, like opening the doors, are coming, and the particles and so. But that's why our model was constructed, so that it might be easier to reason, to put it in contexts. What are we trying to explain? We are not trying to explain the whole picture, but a little piece, so collecting in a cooperation the data. Thank you.
If I can answer to your question, so there is very few studies on that. There is a recent one, negative, but with a pretty poor process of improvement. So it's a recent by Bull in neurosurgery, I think. So there is pretty poor study on that. The second answer is that we are running a clinical trial on that with strong outcomes, surgical site infection other morbidity outcomes. And we hope to fix this question soon by comparing two types of operating room, some of them with an intervention to improve the traffic flow and other without. So, and we'll try to fix this question next year, hope.
Yeah. I fully agree. It's not always wise to keep the endpoint in mind. Like, for instance, patient safety. Everyone talks about patient safety, but measuring that is incredibly difficult. So I think it's important to see the low-hanging fruit. And I think Frédéric's study is a perfect example for it. And if I relate back to the project we do, for instance, we now see that the time between using chlorhexidine and draping is too short. And if you address people to that, you get into dispute. If you can show it objectively, everyone says, yes, it's too short. So those are quick wins and easy to do.
Does anybody have a question in the audience? Oh, yes, please.
Alors, je poserai ma question en français pour que tout le monde la comprenne bien. J'ai remarqué que très souvent, dans les problèmes d'ouverture et de fermeture des portes, quand on faisait remarquer au personnel infirmier que ces allées et venues étaient un petit peu excessives, ils nous disaient oui, mais regardez eux, et ils désignaient des médecins qui en font tout le temps. Alors, je pense qu'il faudrait d'abord que les médecins en soient persuadés. Et que, puisqu'on parle maintenant beaucoup d'exemplarité dans d'autres domaines, il faudrait aussi que les médecins se posent la question de l'exemplarité de leur conduite au bloc, et notamment en ce qui concerne la poursuite des causes de l'infection nosocomiale. Il n'y a pas une cause, il y en a bien entendu plusieurs. Mais déjà, cette histoire d'ouverture et de fermeture des portes, à partir du moment où on peut dire « moi, je ne le fais pas parce que les autres ne le font pas », je crois qu'on ferait un grand pas si on arrivait à en persuader nos équipes. Voilà.
So the comment is about door openings, and when we are saying to nurses to stop opening doors, they are saying, okay, I'm opening door, but the surgeon is also opening. So it's not only me, there is a problem of surgeons and leaders. So the comment was to say, maybe we need to now put the surgeon into the central place for the leadership and for the management of all behavior in operating room, including operating room doors. And if the surgeon is leading this, everybody will follow. So c'est plus un commentaire, it's more a comment than a question. So what's the question about that? It's about, so your question is to say, is the leadership the key?
C'est une proposition de méthode simple, facile et qui ne devrait pas revenir trop cher pour contribuer à diminuer les infections nosocomiales. Parce que tout cela n'est jamais indiqué dans les dossiers.
Not sure it's so simple to manage surgeons and to change their state of mind, but and it's probably different according to countries as well. It was one of my questions. There is a problem of culture around.
But I reckon as well that it seems quite simple, but also the orthopedic surgeons really decided themselves that they had to change. So that was probably the main part of the solution. So, and this just method helped them to have a good dialogue. So it looks simple, and maybe it is, but
it's a system approach, because the surgeon is too busy to watch the door. So you must make sure that someone who wants to enter the door is prevented from doing so.
And well, the surgeon isn't walking away during surgery, right? So it's the team around that will change.
Some of the experience in the UK with different data has shown how competition can be a useful lever for surgeons, as they like to be the best. So who knows? Any other questions, please? Can I see a hand on that? Oh, Pierre?
I have a question to Marlies. Just before you proposed me the topic of the black box, I wasn't aware of this technology, and I have exchanges with a national leader in the field of patients association, and they were dreaming of the black box in an operating room, but the vision of a real black box in case of an adverse event or a crash for a plane. They would be eager to know the truth. So what is your position for the use of this tool in this case?
When you have a crash during surgery, that's whatever happens, you are still obliged to report it, of course, because patient safety comes first. And nothing gets out of the patient file. That's important to realize. We do not strip anything or hide anything from the patient. Only the purpose to collect all the data and synchronize it, the purpose for that is generation of a performance report. So when that has been created, that data has served its purpose. So it doesn't have to be retrieved anymore, but whatever happens at the OR, if there is an adverse event, of course you must report it. But now we see by using black box, in hindsight, we did not see things that were worth reporting. And we are reporting it through the normal system we have. Yeah.
So I have a question. One of my big challenges is aseptic practice outside of the operating theatre. So aseptic technique to perform wound dressings, for example. We have we have aseptic technique, we have aseptic non-touch technique, we have clean techniques, and we have non-touch techniques. So it's very difficult to teach in a standardized way because there's very little evidence to guide must-dos, and practitioners interpret in many different ways. It feels as if the black box technology might be very useful as a training guide for these sorts of situations where there is a lot of interpretation, with the analysis looking to see if the principles have been adhered to. Do you think it might be applicable to use in different situations?
Absolutely. We're not only we're using it now at the OR, but we're setting it up at the trauma department.
Oh, okay.
There's also a lot of interest. We didn't embark on that yet, but on the department who does the endoscopies.
Mm-hmm.
And it's important to realize that it's not only the software that analyzes it, but also the team after the software, in which human resource factor analysts are part of the team. And I also think maybe it's not mentioned yet, but in our hospital we use GCI accreditation.
GS1?
Joint Committee International.
Joint Committee, okay.
Which also focuses on different aspects also for surgical site infection. Like, for instance, we do not shake hands of patients anymore. We just nod and say, how are you? And of course, if a patient reaches out, we take the hand, but we're not the first one to do so. So all those kind of cultural things, if you use systems that can help you see what you are doing and protect you, so you're not afraid of looking at yourself, I think that's enormous gain.
Interesting. Any more questions?
Just one more question. You are especially in serious game. Can you tell us more about what you are doing around that? What's the aim of that?
Yeah, that's a whole different area. But indeed, we use serious games. Why? Because we feel that sometimes people say, I have to train and it's boring. And then there are people say, oh, let's develop e-learning. But e-learning is a PDF behind glass. It doesn't trap into your intricate need to explore. So we use serious gaming to tempt people to try to learn, while they do not focus on learning, but on playing.
Sounds fascinating.
May I just that when we're implementing our standard precautions, of course they have to know. There is knowledge bit that you have to know. But then when it comes to the implementation, we always take the people to the setting and we do they have to practice there, and they will have to provide solutions when there is an obstacle. So we try to do it very on-site, so they participate on it, and it's done in a playful way. It's we don't rely on the course, but the only thing we use the online thing is for giving contents. So people need to have some knowledge inside in order to make decisions. But when it comes to practice, we were trained to do it on site, particularly. I think that the other way around doesn't work well.
I think a beautiful example, it's not mine, but I know an hospital in the Netherlands who has constructed an escape room in which you can only get out if you find solution for several problems related to hygiene. And that makes so much impact to the people participating that they won't forget after more.
Yeah, yeah. We had something similar, but you had to escape from a zombie apocalypse by solutions. Perhaps it's not appropriate for hospitals, but anyway. So, are we done?
Yeah, it's now time to close this session. Just before closing, I will invite you to have a look at the Séclin Sud-Ouest website, who's done a huge job on serious game, and if you don't already know that, I invite you to have a look. So thank you to everybody for being here, for attending to this session. It's now time to close this session, and let's have fun for the rest of the Congress. Thank you.